Before we start the topic for today, is there any question regarding liver anesthesia, which we did yesterday? Mamuna, would you like to ask anything if anything you don't get it?
Yes, sir. I will discuss, but right now I cannot speak, so I will try to text.
Okay. Okay, so today we will try to cover uh, renal anesthesia. Um, so actually, just a second, please. So in the similar fashion, like we try to approach a topic. That not this one. Let's try this thing because I have. Okay. Mm, so what do you think? What are the things which are to be seen when you are somebody told the patient has renal impairment? Okay. What do you think? What are the challenges? Because we will see why the different terminologies we see. Some people say uremia, azotemia. Some people will say renal impairment. Okay. End stage renal disease or dialysis dependent, acute kidney injury. Am I right? So what do you think? What are the problems you can face in these patients? Anyone? Yes, please. Am I audible to you? Can you listen? Can you hear me?
Yes, sir.
Okay, so what do you think? What will be the problems associated with a patient with these terminologies? Actually, I am not very familiar to think this is too clear. Okay. So these patient, for example, if we say that the patient is dialysis dependent, okay, so the problem will be like multi-systemic involvement or in of patient with chronic renal failure. Okay, so the systems, all systems will be involved. There will be problem in CNS, CVS, respiratory system, metabolic system. Okay, and like and there will be some things related to dialysis. So the patient on dialysis, they have electrolyte imbalance. Here also electrolytes. Okay, electrolyte imbalance. They have anticoagulation. They are at risk of infections. They either are with the fistula or with line dialysis protocath related problem. Okay. Uh, okay. So these will be the things which you may be facing. So we will just try to cover one by one. What do you think are the cardiovascular problems? Okay, so in the cardiovascular system, actually, because when the kidney is unable to uh, excrete the water from the body, there will be overloaded uh, circulation. This is one thing. The other thing is that there are chances of hypertension. So when there is hypertension, then a sequence of event, ischemic heart disease, left ventricular hypertrophy, and heart failure, which occurs in any of hypertensive patient. And then also the just a second, please. I think I'm comfortable here. So these patients will be, like I told you, hypertension, ischemic heart disease, pericarditis. Okay, as it's written. So, so just to evaluate the cardiovascular system, as we do, will have to do ECG, chest X-ray, okay, echo, and uh, if then again according to the risk factors, we will be uh, proceeding. Okay, then respiratory system, again there will be because of overloaded circulation, there will be chances of patient going into pulmonary edema, and there will be chances of infections as shortness of breath, and because when there is for example, also because there is anemia. So what happens to oxygen hemoglobin dissociation curve in anemia? Actually, nobody is speaking out, though. So I cannot give a lecture and close the. Someone has to speak out. Cannot all of you sit mute? Any volunteer, please. Dr. Sohail, Hassan, who? Yes, speak out, Hassan. What's the issue? Okay, so oxygen hemoglobin dissociation curve will be shift to the right. Also because kidneys are unable to remove the acid, so there is metabolic acidosis. So acidosis also shifts the curve to the right side. Okay. So okay. Okay. What are the reason for uh, coagulation problem and bleeding tendency in patient with CRF? It's because of platelet dysfunction. Okay. Because the coagulation cascade at the end, there is interaction between the coagulation factors, von Willebrand factor, factor 8, for example, and platelets. So in the basic problem in liver renal failure is the vascular abnormality. So so now the numbers, the normal coagulation profile which we do, PTINR, may be normal. Okay. But still there will be chances of bleeding. So we need to do either platelet function assay or this clotting time, bleeding time, to see any problem. That's why regional anesthesia is always a question mark. Okay. In the exam, if you have any doubt, don't commit, because if you similarly is with the end stage liver disease and end stage renal disease, unless there is compelling indication, okay, it's never 100% safe. So you can say the same thing which I always tell you, risk versus benefit. Okay, you see, I have forgot to share the screen and nobody has even told me. I was just telling this platelet dysfunction, vascular abnormalities, never commit, don't commit unless strong compelling indication, risk versus benefit. Okay. So up till now, we have just discussed that there is problem in the CVS, respiration. Why there is anemia? Anemia is of multifactorial reason. Okay. There is
because of erythropoietin deficiency.
okay. Is it the only reason, erythropoietin, or there are some other reasons? Because erythropoietin, okay. So there is also a tendency for bleeding. What is the role of erythropoietin? What is the role of erythropoietin? It is for RBC production. Okay. So when there is problems with the erythropoietin, so this is one reason. Then there is anemia of chronic disease. Okay. Then there is bleeding. So the reason of anemia is multifactorial. Okay. Just a second. As iron deficiency due to repeated blood loss with hemodialysis and associated peptic ulcers. B12 and folate deficiency due to poor diet, they have nutritional problem, they have gastroparesis. Uremia depresses erythropoietin production. Uremia reduces RBC lifespan. Okay, so that's why, but they are compensated. Usually they are tolerating the low hemoglobin. Okay, and they are tolerating it with the shift of oxygen hemoglobin dissociation curve to the right with increased 2-3 DPG and increase tissue delivery. Okay. Then repeated whenever they are having this dialysis, they are receiving anticoagulants as well. So that can also cause bleeding. Okay. So this is another thing which is important. Blood clotting we have discussed. Bleeding time is prolonged, as I told you. Intramuscular injections are always, you see, risk versus benefit, as I told you. So it is better because you don't want to be a hero. You want to be safe. Okay. So I will suggest you that in the oral exam, it is difficult to defend this one regional anesthesia, especially central neuraxial block in a patient with CRF. Okay. Like for example, creation of AV fistulas, you can give supraclavicular block or like any brachial plexus block because it will not be a very deep block and there will be less chances of bleeding, and bleeding can be controlled with the pressure. Okay, especially if you are in axillary block or is this one supraclavicular block. You can press it in scalene, you can press it. Okay, so this is another thing. What else? There is because usually what are the by the way, what are causes of CRF? What are different causes of CRF?
Yes, I was thinking about it because when we see a patient with end-stage renal disease, we can divide our, things in two category: the cause leading to the congestive renal failure, and then this renal failure, how it is affecting other organs, as you described.
Yes.
So,
Diabetes, hypertension, glomerulonephritis, patients. What is the musculoskeletal disease like rheumatoid arthritis? Okay. This HLA-B27 related seronegative spondyloarthropathies. Okay. Contrast
contrast induced even. So we can divide it into pre-renal, renal, or
herbal.
post-renal sort of as well.
Yes. Actually, we usually
That is it.
actually there is a window we have to create acute kidney injury leading to chronic renal failure. Can anyone know how will you like how will you label it? Like how will you assess? How will you tell that this is acute kidney injury and this is CRF?
There are
According to
criteria.
reversibility. And what
Okay.
about this rifle or akin? Okay. And how do you classify it? When it develops CRF based on cortico medullary
Medullary.
differentiation. One thing, other thing, creatinine.
Creatinine level. How much? How the times it is increasing, and from the baseline, how much creatinine is increased,
Yes.
and urine output. Of course, in a specific
GFR.
duration as well.
Actually, not exactly urine output, according to GFR.
Okay.
Okay, because when GFR is decreasing, then you label it as mild, moderate, or severe, and then end-stage renal disease. Okay. And because of CRF, uremia, or these all complications can occur. There will be some complications which are acute. What are acute problems related to? Like, for example, because I'm trying to cover as many things, what will be the ASA status of patient with end-stage renal disease?
If it is on dialysis, control ASA3.
Very good. When will it become 4?
Acute renal failure,
No,
or
not acute renal failure. If
AKI
you
on CKD sort of state.
no,
Or
specifically you can tell about hyperkalemia.
yes,
Okay.
hyperkalemia, acidosis, sepsis, any
Pericarditis.
other. Okay. Severe systolic dysfunction, active myocardial ischemic condition.
Like anything which is now becoming, like, for example, if there is active cardiac conditions. Just for revision, what are active cardiac conditions? Just as by mistake, I mute you. Please unmute. And anyone wants to speak out, please just raise the hand. Okay. Muna, please unmute yourself.
Okay.
What are
active
cardiac
conditions? Symptomatic arrhythmias. Type 2.
Actually, not symptomatic arrhythmias, severe
and type
arrhythmias.
3.
Severe arrhythmias like
arrhythmias with
bradycardias,
tachyarrhythmias and yes,
SVT,
bradycardia,
atrial fibrillation.
yes, SVT.
Okay. So this is one. And before that, it is better to start with acute recent MI. What is difference between acute MI and recent MI? 7 days and 30 days. Then unstable angina. like angina. How we classify angina? Canadian class 3 and 4. This is unstable angina. Okay. Then decompensated heart failure.
Decompensated heart failure.
How will we quantify it? According to
NHY
3 and
class
4.
3 and 4 dyspnea.
Actually, this is very simple. If you just cram it in this way, that Canadian class 1 and 2 is in clinical risk factors, and 3 and 4 are here. Similarly, NHY 3 and 4 are here, and 1 and 2 are there in clinical risk factors. Okay. And severe valvular disease like tight stenosis, aortic stenosis, and tight MS. Okay.
Yes.
So you will label it as ASA4. Is if any of the active cardiac condition comes, then it becomes ASA4. Okay. So just to recap, what can be the finding in ECG, echo, chest X-ray, ABGs? Because practically we approach like this. Am I right? Serum electrolytes, urine function test. What about liver function tests? They are low in albumin or no? Why they are low in albumin?
Due to 2 reasons. One
Because
is
of the
due to
renal loss of albumin.
Yes. Proteinuria also occurs, especially if it is glomerulonephritis, because of glomerulonephritis. Okay. So there is no specific changes in ECG. There will be according to the situation, according to ischemic heart disease or hypertension or LVH. So if they ask you anything specific, there is nothing specific. And similarly, in the echo, because they are prone to have ischemia. So all the findings which we have discussed in detail, if someone has not seen it, I will highly suggest you will find it in the playlist for cardiac. So I will highly suggest you to look at that. In chest X-ray, overloaded state, and like similarly increased cardiac shadow and things and like that. ABGs, there will be chronic acidosis, compensation, or mixed disorders you will find, because there will be involvement of pulmonary system as well as metabolic system. Okay. Serum electrolytes. What are the findings in electrolytes? Increase potassium, increase. What else? Yes, sorry, I was disconnected. Can you hear me now? Can you hear me now?
yes, sir. Yes,
Yes,
sir.
sorry. So what about electrolytes? What will be the problems related to electrolytes? Sodium is increased or decreased?
Sodium is decreased and potassium is increased.
Okay, and what about phosphates?
Phosphates are higher initially and then later on it decreases in later stages of chronic renal failure.
Okay, because we have missed one of the aspect. What is the relation between vitamin D, calcium, parathormone? What happens with it? From where this vitamin D is coming? GIT.
I
Vitamin
think
D
so. We
is
cannot see your
basically blocked from the
screen.
GI tract,
Okay. Then what
and
is the role of kidney?
basically because of the low calcium, chronic renal failure leads to secondary hyperparathyroidism.
No, just a second. Just what happens normally with vitamin D? It is absorbed by GIT. Then what is role of liver? What is role of kidneys?
Then it undergoes activation in the liver and the kidneys, finally in the kidneys by the alpha-1 hydroxylase.
And then what is role of vitamin D with calcium? Vitamin D is necessary for the
Vitamin D
absorption.
basically causes
Sir, I
absorption of
think so.
calcium
We
from the
cannot see your
intestine.
screen. Sorry.
Just a second. Just a second, please. Actually, I was, I think, disconnected. Okay. Okay. So now, what is role of GIT? What is liver? What is role of kidneys? And then what is a relationship between calcium, phosphate, this one, parathyroid hormone, calcitonin. Okay. Can someone explain?
Vitamin D basically causes absorption of calcium from the intestines and causes deposition of calcium into the bones.
Okay. So what will happen here?
Parathyroid hormone causes uh, releases calcium from the bone
Okay.
and increases the serum calcium levels, while the calcitonin is responsible for calcium deposition into the bone.
Very good. So you should be should have a clear concept about what is the relationship between all these things. Okay. Otherwise, you will not be able to. Just a second. Actually, I had opened it. So many files are open. I missed it. I just wanted to show you. Just tell me one thing. Somebody said that sodium will be high. Is it sodium will be high or low?
Sodium will be low. Sodium will be low. I said low.
Okay, so that's what, because patient is unable to conserve sodium actually. Okay, in the initial phases, there will be retention. Okay, but later on, when the kidneys are not able to have any ionic channels are distorted, they are not functioning, then sodium may be low as well. Okay, especially because whatever
Yes, so
occurs.
basically there are two reasons for hyponatremia here. Can I?
Okay, yes, please.
There are two reasons for hyponatremia here. In later stages of the kidney failure, there is decreased tubular absorption of the sodium because of the damage to the tubular cells. Number one.
Yes.
Number two, as we know that there is fluid overload or the volume overload in chronic renal failure, this also leads to hyponatremia.
So it is dilutional. Okay. Because of more water uh, absorption. Okay. Like not water, kidneys are not able to clear. There is overloaded. Then another thing, when the patient is undergoing this dialysis, this is another problem which the patient face is disequilibrium syndrome, and it is actually related to sodium levels. Am I right? Okay. So we will just revise some of the things like diabetes, hypertension, glomerulonephritis, polycystic kidney disease. These are common. So don't say that only sodium is increased. Sodium is decreased actually later on. Potassium. Okay. And just a second. Because patient is unable to remove the acids, there is acidosis. Okay, and this is also showing there is nephron is restricted. Okay, phosphate levels increase, and there is deposits of calcium, metastatic deposit, and there is a decrease in ionized calcium. Okay, parathyroid hormone, it is like there is secondary hyperparathyroidism. Okay, to cover it. So this is all because of vitamin D, calcium is not absorbed from GIT. So it is also causing hypocalcemia. So you should be knowing about the interlinkage about it. Okay. We discussed about this vitamin D as well. Okay. So few words about like these problems are there. So how will you what changes will you face when you are conducting the anesthesia? What will be the challenges? Like, for example, GA versus central neuraxial block versus peripheral nerve block. So you can give superficial blocks, but if you have any doubt, you will not go for deep block. Similarly, this is always a question mark in plus minus. When you are giving GA, what things you will be seeing? If the patient is dialysis dependent, you have to make sure this dialysis preceding surgery. Okay. And you should better to have post dialysis labs, especially electrolytes, because this patient can have electrolyte imbalance. Even this patient can be hypovolemic. Okay. And this thing will be increased hypovolemia and autonomic dysfunction, especially if the reason of CRF is diabetes mellitus, which is one of the most common causes of CRF. So diabetic patient, they already have autonomic neuropathy, which will be exaggerated if there is hypovolemia post dialysis. This is one thing. Then if there is line, you have to take care of the lines and lines related problem. And if you have fistula, so you have to care for the fistula. What are the things which you be doing? No IV lines on that side, no BP cuff, no arterial line. What else? You have to protect it, cover it, label it.
And label it, and also everybody in the theater post-op, some as we in our setup label on the bedside that there is fistula on left side, so no venous or arterial puncture should be done on that side even by any lab technician.
Yes. So
So
actually, this
what's
is
about
theoretical, but if you have to take arterial line in CRF patients, theoretically, I have never done it. I don't know people do it or not, but dorsalis pedis theoretically, you have to tell about the dorsalic pedis. Okay. Artery, dorsalic pedis artery for
yes,
A line.
yes, we do in our setup. So what's
Okay.
about the venous thromboprophylaxis in this patient? We have not discussed this yet.
Thromboprophylaxis actually, according to the this one, because you have to see the patient factors, type of surgery, and because these patients are already receiving anticoagulants through this one uh, and this one through dialysis. If you are giving Plaxane, what you need to do? You need to reduce the dose. Am I right?
It's because we
Yes.
have seen in routine that these patients sometimes patient came with fistula problems like dysfunction of fistula due to any reason.
Mm.
So when they have central venous hemodialysis catheter or line such, then there is chances of thrombosis, venous
Yes.
thrombosis.
Yes, you are
So
absolutely
that
right.
is also in a
So you have
consideration
to give
because
actually
when
the
we are going to plan.
yes. Okay. So, but this thing you just reminded. So, Claxane dose will be reduced. Okay. There will be the prophylactic dose will be reduced in these patients. Okay. So, what about pre-medication with caution? Okay. Better to avoid.
Yeah, they are considered, yes, they are considered as full stomach, so we can
Aspiration
consider about the
prophylaxis.
aspiration prophylaxis. Yes.
Okay.
So if
Among
the patient is having difficulty airway, anticipated, we can give anti-sialgo to reduce the secretions. It is always
okay.
difficult to pronunciate.
Okay. So what about choice of induction agent, and whether it is rapid sequence induction or modified rapid sequence induction? Can you use rocuronium?
Modified sequence induction with the titrate.
Yes, if you have
No,
uh,
no. We cannot
if you have
use rocuronium if the GFR is less than, I think so, 25%. Yes, if patient is on dialysis, so we will avoid rocuronium.
so again with the similar to yesterday, cisatracurium is the best choice. Okay, among the rocuronium, if you have Sugammadex, then you can give or no.
I think so, no.
If you have Sugammadex, you can give, because this is not metabolic interaction. It's actually a binding, and this complex is inactive. Okay, so it will
Yes, then
engulf
that can be excreted.
rocuronium. Okay, but of course nothing is 100% safe. So but you can give, because you, what about succinylcholine? Is it safe?
So it says your voice was discorded. You are talking
What
about
about
sucks? Yes, if
succinylcholine?
it is safe if there is normal serum potassium levels.
How much potassium is raised by it?
0.5 milliequivalent per liter.
Okay, so if for example already they have 5, it can become 6, for example.
So
So
of
it's
course,
not
the risk versus benefit is the
risk versus benefit. So again in the exam you can say that I can depotash. How can you depotash or prevent or make your body stronger in that scenario? You can give some bicarb, you can give insulin dextrose. Okay, you can give calcium
agonist.
gluconate or chloride. Okay, beta 2 agonist. Okay, and if the patient already underwent dialysis, like you have to outweigh risk versus benefit. Okay, what about analgesia? Paracetamol, yes. NSAIDs, no. Rest of the things, sorry.
Uh,
Yes.
Sir, regarding the muscle paralysis, I had a point that when the CRF patient comes to trauma for emergency surgery, then our choice will be rocuronium or succinylcholine, because that time we don't know the potassium level, so risk of hyperkalemia is more. So why shouldn't we go for rocuronium, even though it will cause a prolonged muscle blockade? But at that time, it should be our first choice, even if
No,
Sogamadex is not available.
yes, actually, you know, in the exam, in the Viva oral exam, you always use this word. This is for your savior. This word risk versus benefit is your savior. If you are using succinylcholine, still you can, whatever I have told you, this beta agonist, insulin dextrose, you can use it. Am I right? It will, even if it is more, you can counteract it. This is one thing. And if you have rocuronium, yes, you can use it. Okay. Am I clear, Hassan?
Yes, sir.
From manufacturer does not recommend to give Sugammadex. I doubt. I think we can give Sugammadex in renal failure. There is no problem. Just reconfirm it because I use it, and theoretically, because the problem is with the active complex. For example, if there is something active, then it's a problem. Because it's
Yes, sir. I have read about this, that there is no problem with Sugammadex, but there is in relative contraindication with GFR less than 25%. Avoid the rocuronium. But with
yes,
Sugammadex, it is safe to use.
yes. If we like in this scenario, you have to outweigh risk versus benefit. You can use neuromuscular this one monitoring, okay, and then you can this one avoid the repetition, repeating the dose, okay. So intubating dose, actually all this dynamics is how you are using it, even for practical purposes and for exam. In exam, it is better to be on safer side. Don't use a closed-ended word, okay. So what else is left?
Sir, IV versus inhalational anesthetic, what will be the best? We were talking about induction agents.
Desflurane will be better
Yes.
because, and among sevoflurane, it has 2% metabolism, and it can cause this theoretically this compound A, which is nephrotoxic. But anyways, for practical purposes, you can use it. Isoflurane has less metabolism than sevoflurane, okay. And what about propofol, thiopentone? They all can be given according to the. It's not there is any problem because there is no active metabolite with propofol or thiopentone, so there is no problem. You can use it. Morphine
So if there is
is
hemodynamic instability, so we can give it omidate, right?
titrated. Atomidate, again, I tell you something. You can say that this is titrated doses. If you are giving propofol, you are anticipating sudden hypotension. With atomidate, it will be good. It will be good. But again, if you are giving atomidate, it will can cause adrenal suppression. Okay. What about ketamine?
Yes. It has no ketamine active metabolite, which is excreted by kidney.
So again, as an
I think so
analgesic,
with low dose.
analgesic dose will not be a problem. Okay. 0.5 milligram per kg. What else? Among, again, the same, actually, these are, if you just try to understand these, analgesia is almost the same in renal failure or liver patient. Okay. Remifentanil is the best one. You can give fentanyl in small doses. Okay. What else? And the similar intubation and extubation responses, stress responses, post-op, HDU. This is common for both of them. Okay. If you have patient with creation for AV fistula, in addition to what we have discussed, what is role of this brachial plexus block? Is there any role in AV fistula creation?
Yes, sir.
Why? What is that?
We can give the brachial plexus block with the T2 intercostobrachial block.
This is
And
something else. I
for the
wanted to tell
formation
you.
of fistula, yes.
Yeah, it actually improves the graft because sympathiolysis. Okay. So it's associated with success, increase chances of success. So this is in addition to,
Sorry, sir, I cannot hear because of
I'm sorry,
interruption or
because
distorted voice.
yes, I'm saying that if you are giving brachial plexus block for the creation of AV fistula, there are more chances of success because of sympatholysis. So there is dilatation. Okay.
Okay, sir. Thank you.
So it is also related to the success of AV fistula. Okay. And actually, especially in any block, you can tell this thing, but specifically because you have to label which side, because even there is a chance that usually if they don't label, you can give on the wrong side. This is a common mistake. If you are not identifying, if the site is not labeled, you can give the block on the wrong side. Okay. Okay, so
Sir,
I
have
think
you discussed anything else about the AV fistula? Because I was just got disconnected.
no, AV fistula, I just told that AV fistula success will be increased with use of brachial plexus block. And when you are giving this block for AV fistula, make sure to discuss with the surgeon which side they are doing the fistula, because it's possible to to give on the wrong side. Okay. What about
Okay, sir.
insulin?
Yes, sir.
Insulin.
Mm,
Means
sir, there
half-life
is
of insulin is increased. Okay. Because metabolism is decreased.
The duration of action of insulin is prolonged. So we
Yes.
have to give decreased dose.
Okay. And I have just tried to cover the main aspects. Nitrous oxide can be given. There is not much problem, but what will be the relationship with nitrous oxide? It is because they are chances of post-operative nausea, vomiting will be increased. Okay. Any question, please? Actually, usually they will be asking you in a scenario that you have a patient with end stage renal disease for any procedure. Okay. So if you have a patient with tendency for bleeding and you are having, for example, they can ask you with femur fracture, neck of femur fracture. They can ask you with the dialysis, this one, AV fistula creation, actually. Okay. They can ask you for any elective. What about elective surgery? Will you do it in renal failure or no? Like, for example, if there is a lap chole. Is lap chole elective surgery purely? Actually, it's a planned surgery.
no, sir.
It's a
No,
planned
not
surgery.
always. No, if there is gallbladder empyema, then
The planned surgery, that's what I'm telling you, that it's not elective surgery. Elective surgery is actually cosmetic surgeries. Joint replacement. Okay, plastic surgeries. So lap chole cannot be delayed forever. If you delay it, it can cause problems. So always say that it's not an urgent surgery. Always, it is a planned surgery. Okay, Mamuna, you are clear? I'm saying the same thing which you are saying. Like
Yes,
if
sir.
you
Yes, sir.
you
Yes,
cannot
sir.
delay it because actually in a real sense, there is some overlapping between the word emergent and urgent. Emergent is within minutes. Urgent is within hours. Okay. Similarly, planned
Yes, sir.
is from days to few weeks, and elective is for months, and you can delay it forever. You don't, if you have something which is a constant threat to life, you will never do elective surgery. Okay. Uh, Actually, they will be asking you some words about dialysis. One is like intermittent, and one is CRRT. What is difference between CRRT and intermittent?
Sir, continuous renal replacement therapy takes place over a period of 48 to 72 hours,
Okay.
while
More
intermittent hemodialysis is another.
more stable. Okay. Like
Yes.
intermittent hemodialysis may not be feasible in a number of patients, but CRRT, they are, and actually, if you did in simple words, they are removing more of water. Okay. What is that mechanism for this hemofiltration versus hemodialysis? This occurs with the concentration gradient, am I right? Across a semi-permeable membrane. And this is occurring with the convection, what is called as solvent drag. Am I right? I had not recalled it. I just opened the page just to. Yes, Mamuna, is it okay?
Yes, sir. Today, actually, I have very signal problems as well. I think so. Hemofiltration is against the concentration gradient of fluids, right? And
Yes.
hemodialysis.
Hemodialysis is with concentration gradient across a semi-permeable membrane. Okay. With a
Yes.
dialysate fluid, and hemofiltration with solvent drag or solute drag. Okay.
Okay, sir. Thank you.
So, okay. So I think we will stop here. Actually, because ideally we need more time for covering these, but I'm just trying to give you an insight because in the exam, I just a second, let me show you one thing which I wanted to tell you. Because this case can come as a long case with the renal failure, and of course there will be more than one problems in this. Okay, so you can this is a mnemonic, a wet bed, acid base balance, water balance, electrolyte hemostasis, toxin removal, blood pressure control, erythropoietin synthesis, vitamin D synthesis. Okay, and similarly, in similar fashion, you will be evaluating the patient, which I was telling you. This you don't need to um, memorize each and every line of these criterias, but you can just say that it is according to the duration, according to the serum creatinine, and according to the urine output. Okay, or GFR usually, and there will be some obvious cause of renal failure, and in some patients not identifiable cause. Okay. If it is like any rhabdomyolysis or contrast induced or any hypoperfusion, shock, any surgery, for example, you can just think about it, patient factors, surgery related factors, anesthesia related factors. Just you can think about it, that what are the problems in anesthesia. If you are hypoperfusion, it's a renal risk. Hypovolemia, it's a renal risk. If they are cross clamping with the decreased renal perfusion, it's a renal risk. If you are using too much NSAIDs, it's a renal risk. So that's how you will be approaching. Okay. So as I told you, that chronic kidney disease with the ultrasound.
Corticomedullary differentiation.
Okay. So post-renal actually is obstructive causes. Usually as an anesthetist, when they are asking you about
Irreversible.
CRF, usually they will be asking you about pre-renal. The most important, then renal, and post-renal will be related to obstructive uropathy, in which hydronephrosis occurs. Okay. So one of the patient in which you have to rule out hydronephrosis is in TURP.
Ureteric
Okay.
stone.
Ureteric stone, or specifically TURP, because TURP patient, when with this prostatic hyperplasia, there are chances of this one obstructive, because of obstruction there is chronic increase in pressure and it is causing hydronephrosis. Okay.
Sir, I have a question. If if some patient is already on dialysis, already had enough renal damage, then why we are avoiding answers? Is it because of the renal damage or because of answers induced, reduced prostaglandin production and other reasons?
And there is another thing. Is it it has relationship with some bleeding, some gastric bleeding?
Yes. Nice.
Okay. So this is more of the reason.
Okay.
You have a very valid question, but usually there are a number of factors, because always there is some urine production which is going on, even unless the patient become anuric. Okay. And especially NSAIDs is related to this one acute renal injury. Okay. The
Yes, sir.
use, and especially the patient at risk. You will have patients with end-stage renal disease. This will be one category, but majority patients you will be facing, even practically, you will have like you can say at risk. Like for example, diabetic patient who has a baseline renal failure. Now he is at risk if you give more NSAID, that can create acute renal injury on top of chronic renal impairment. Okay.
Okay, sir. Thank you.
So similarly, these are the general symptoms. Remember, for fluid overload, same symptoms. Chest pain, same symptoms. Ischemic heart disease, same symptoms. Orthopnea, PND, same symptoms. Okay. So actually there is nothing special about it. Similarly, clinical examination, again, I will use the same thing, that renal system will be affecting cardiovascular system in the same way that it will be an overloaded state. There will be involvement of the right side of the heart and the left side of the heart accordingly. Okay. Overloaded state will be causing like left ventricular hypertrophy, right ventricular hypertrophy, chances of pulmonary edema. So you don't need to think that there is something special about renal. No, it's all renal, liver, heart, and lungs. These all will have, any of the system will be involved, almost the same symptoms and signs. Okay. So this is a very good article. I think
Okay, sir. Thank you.
I will highly suggest you to have a look. We have discussed actually, yes, hyperphosphatemia, and there is cholesterol is also high. So there will be role of lipid lowering drugs, okay, which is increasing the survival. So this is for long term, and urine analysis, cardiac investigation. I have this is a mnemonic AEIOU for acute indications of dialysis. Okay. I talked about pericarditis, development of encephalopathy, overloaded state. Any, I always forget it, but please, they can ask you what are the dialysable and non-dialysable drugs. Okay, you should be knowing about it. What are the drugs which are dialysable and what are the drugs which are non-dialysable? Okay. So I think, I just try to give you an idea as much as we can discuss in one sitting. And now whosoever is listening, they can just go a little depth. I'm just telling a number of questions they can ask you about dialysis, CRRT, mechanism, hemofiltration, hemodialysis, what are the indications, what are the problems. There will be some acute problems, there will be some chronic problems, line related problem, fistula care, and the effect like electrolyte imbalance, acid-base disbalance, cardiac depression, the etiology of the cause, and if there is a patient at risk, the patient had trauma, now that there is or crush injury, now this patient can go in renal failure even later on because of myoglobin rhabdomyolysis based myoglobin, or if the patient remains hypovolemic, there is decreased hypoperfusion, hypotension, then it will be later on, the patient can lead into renal failure. Okay. So thank you very much. Tomorrow, I think we will try to have some words about some neuromuscular diseases. Okay. So you read about Memuna, especially you think about myasthenia gravis, polio,
Okay,
these
sir.
ICU acquired muscle weakness, okay, tetanus. We will just try to cover as many topics as possible. Okay, thank you very much.
Thank you, sir.